Greetings from Mumbai, India, and a big hello to everyone watching this lecture from different parts of the world. Today, we begin our lecture series on implant overdentures with the first part addressing the prosthodontic principles involved in understanding the science and the intricacies of the overdentures, and in the subsequent lectures we will be addressing individual treatment plan of implant overdentures with different attachment systems. At the outset, let me take this opportunity in thanking my beloved Dental XP family for giving me yet another opportunity to address all of you wonderful clinicians and researchers present globally, and I definitely feel privileged to be part of this organization. So the first question we will be addressing is why? That is, why overdentures? We are all aware as to what problems occur with a mandibular complete denture, especially with a thin mandibular ridge deficient in the bone height, width, or both. Stability of the denture is then questionable. Forget retention. That's when implants come to our rescue. We are all aware that implant dentistry has revolutionized the art and science of modern dentistry practiced worldwide and has given us a new lease of life to the restorative aspects involved in day-to-day practice. Insertion of implants for support of overdenture creates a more favorable environment for the restoration. What are the advantages we are looking at? The location of the mandibular implant supported overdentures can be planned on specific sites, and their number may be determined by the restoring doctor and the patient. In addition, the overdenture implant abutments are healthy, rigid, and provide an excellent support system. We are also aware that there is minimal bone resorption of the residual ridge which occurs after the placement of implants. On the other hand, if we consider the extraction of mandibular teeth, there is an average 4 mm vertical bone loss during the first year following treatment. This bone loss continues over the next 25 years, with the mandible experiencing a 4-fold greater vertical bone loss than the maxilla. Now, the same bone, when present under an overdenture, may lose as little as 0.6 mm vertically over a 5-year period, and the long-term resorption remains at 0.1 mm per year. The bone loss also dictates the appearance of the inferior third of the face. Overdenture thus provides greater support of the lips and the soft tissues of the face than a fixed prosthesis. Also, the denture tooth provides an aesthetic replacement for natural teeth. Now, what we also have to consider is the movements that occur. A mandibular denture may move 10 mm during function. Under these conditions, designed occlusal contacts and the control of masticatory forces are near impossible. However, an implant overdenture provides stability of the prosthesis, and the patient is able to consistently reproduce a determined centric occlusion. Soft tissue abrasions and accelerated bone loss are more symptomatic of horizontal movement of the prosthesis under the lateral forces. An implant overdenture may limit these lateral movements and redirect forces more longitudinally or axially. Now, talking about the chewing efficiency, the chewing efficiency with an overdenture is improved by 20% compared to a conventional complete denture. The maximal occlusal force of a denture patient may improve by about 300% with an implant supported prosthesis. The stability of the overdenture is also improved when we compare that to a traditional denture. The mandibular complete denture, as we've already mentioned, moves during the mandibular movements and also during speech. The contraction of the mentalis, buccinator, mylohyoid muscles may lift the denture on the soft tissue. As a consequence, the teeth may touch during speech and elicit clicking noises. The retentive implant overdenture remains in place during the mandibular movement. The tongue and the perioral musculature may resume a more normal position because they are not required to limit the mandibular movements. These mandibular movements were explained in details in the first lecture, which was on timing of occlusal contacts. The implant overdentures may also reduce the amount of soft tissue coverage and the extension of the prosthesis. This is especially important for new denture wearers or those who have low gagging thresholds. The existence of a labial flange in conventional dentures may result in exaggerated facial contours for the patient with recent extractions. Implant supported prostheses do not require labial extensions or an extended soft tissue coverage. The soft and hard tissue defects from tumor excisions or trauma do not permit the successful rehabilitation of patients with traditional support. Therefore, hemimandibulectomy patients and other maxillofacial patients may be restored with an implant overdenture. There are also various advantages as far as hygiene and home maintenance go. They are vastly improved with an overdenture compared to a fixed prosthesis. Professional maintenance is also improved. Peri-implant probing is diagnostic because a crown is not on the abutment, which prevents a straight line access to the crest of the bone. The overdenture may be extended over the abutments to prevent food entrapment during function. Speech compromise again is not present because the denture may extend to the soft tissues in the maxilla. Another advantage being, an overdenture may be removed at bedtime to reduce the effect of nocturnal parafunction and increased stresses on the implant support system. It may provide stress relief between the superstructure and the prosthesis, and the soft tissue may share a portion of the occlusal load. The prosthesis is easier to repair than a fixed prosthesis. There is shorter restorative appointments, reduced laboratory fee, fewer implants. Therefore, the patients can afford it because it's available at a reduced cost compared to that of a fixed prosthesis. There is also improved nutrition, psychosocial status because the denture tends not to move in the mouth during function, increased comfort, and aesthetics. What about the indications? Well, the major indications being that if a patient encounters lack of retention or stability with conventional dentures, implant overdentures definitely come to the rescue. If there is lack of function, difficulty in speech, patient encounters tissue sensitivity, or there are frequent soft tissue abrasions, implant overdentures should be the treatment of choice. Does this treatment modality have its disadvantages? It does. Well, when we talk about implants, patient generally has a perception that it is going to be something which is fixed. So when there is something which is removable or not fixed, it acts as a setback to most of the patients. Therefore, an overdenture would not satisfy the psychological need of those patients who feel that the prosthesis should be a part of the body. Lack of interarch space makes an overdenture system more difficult, because when we need to have the bar components or the other attachment systems, we have to consider that we need space for the overlying acrylic and the denture teeth. Therefore, to begin with, it's important to understand as to what is the interarch distance available. Therefore, if required, an osteoplasty may be done to increase the interarch space, or in those instances, a fixed restoration is indicated. Coming to the mandibular implant site selection. The greatest height of the available bone is located in the anterior mandible, between the mental foramina or the anterior loops of the mandibular canal when present. This region usually presents the optimal density of the bone for implant support. The available bone of the anterior mandible is divided into 5 equal columns, serving as potential sites as A, B, C, D and E. All 5 implant sites are designed at the time of surgery. In this way, the patient always has the option to obtain an additional implant support in the future. Also, if an implant complication occurs, the pre-selected optional sites permit corrective procedures. If implants were placed in the A, B, D and E position and an implant fails to achieve rigid fixation, the mobile implant may be removed, add an additional implant placed in the C position at the same time. This saves an additional surgery and eliminates the time required for bone healing before an implant could be reinserted into the same location. What am I trying to stress is that an organized pathway is provided for additional support or for the management of complications. Now let's have a look at the overdenture movements. Why do we need to know this? Because there are many types of precision attachments which are used in implant overdentures. The motion may occur in one of the 6 directions. It can occur occlusally, gingivally, facially, lingually, mesially or distally. Right? What we have to understand is that the actual overdenture movement may be completely different from the attachments when independent. Also, the prosthesis movement may vary from 1 to 6 directions even though the same type of attachments is used. Okay, let's see it in details. If the prosthesis is rigid while in place but can be removed, the prosthesis movement PM1 is what occurs. PM1. Okay. Now, for example, the O-rings have a range of motion of 6 different directions. But if the O-ring is placed on a complete arch bar in 4 different sites and the prosthesis rests on the superstructure bar, it may be a PM1 restoration movement. Okay? A hinge-like prosthesis movement permits action in 2 planes. A hinge, action in 2 planes. Therefore, it's a PM2 prosthesis. So what is an example of that? The header bar and the clip is a type 2 attachment. When this system is placed perpendicular to the axis of prosthesis rotation, the PM will also be in 2 planes, PM2. However, If the header bar is at an angle or parallel to the direction of rotation, the prosthesis is rigid and a PM1 system takes over. So it's important to understand that the components, when placed in different scenarios, permit the movements which can be either PM1 or PM2. An attachment system which permits vertical movement, if it's a hinge, it's a PM2, but if there is a vertical component added to it, it's a type 3 system. If header bar was type 2, then we have a dolder bar and a clip, which is for the PM3. The bar and clip must also be perpendicular to the direction of prosthesis rotation for a PM3 movement. Coming to the PM4, it's rarely available for an overdenture system. The PM5 allows the motion in all directions. When I'm talking all directions, it is occlusal, mesial, distal, facial, lingual, all directions. What can be the example you can think of? Magnets. It's the most common implant attachment systems which illustrates a 5-direction movement. However, the implants usually must be independent for this range of motion. If a superstructure connects the implants, the range of motion decreases. Independent magnets provide excellent retention but poor stability of the prosthesis. An O-ring or ERA attachment also corresponds to 6 direction of motion. However, the implants may need to remain independent to permit a PM6 range of motion. Now, is it clear? Now, coming to the conventional overdentures treatment options. What are the treatment options that we have in hand? The overdentures can be option 1, 2, 3. In 3, it can be 1 or 2. Overdenture option 4 or 5. Let's look at the options. Let's just skim through the facts before we go into individual details. If it's overdenture 1, the implants are placed in A and E position, independent of each other. The prosthesis movement is 6. Posterior ridge should have a good anatomy, stability, and denture retention would be good. If it's overdenture treatment option 2, implants are placed in B and D position, joined rigidly by a bar. Prosthesis movement ranges from 3 to 6. Posterior ridge, good anatomical ridge form, stability, and denture retention. If it's overdenture option 3, if it's the first instance, the implants are placed in A, C, and E position, rigidly joined by a bar. If posterior ridge form is good, prosthesis movement ranging from 2 to 6. However, the posterior ridge needs to have a moderate to good posterior anatomy. Good lingual flange on the denture is a requisite. If it's overdenture treatment option 3 part 2, implants are placed in the B, C, D position, rigidly joined by a bar cantilever to the distal by 10 mm. Prosthesis movement ranges from 3 to 6. Posterior ridge, poor posterior anatomy, poor lateral stability in the posterior region. In those instances where we want overdenture option 4, the implants have to be placed in A, B, C, E position, rigidly joined by a bar cantilever to distal by 10 mm. Prosthesis movements ranges between 2 to 3 mm. Posterior ridge should have poor posterior ridge anatomy and or patient desires. Overdenture option 5 has to be chosen. Then the implants need to be in the A, B, C, D and E, all positions rigidly joined to a bar cantilever to about 15 mm. Prosthesis movement 1. Used in those instances where the posterior ridge has a poor ridge form and or patient desires. Let's look at every single option, that is the overdenture treatment options, starting with option 1. This is rarely indicated. The patient's desires are minimal. Anatomic conditions of the mandible are good to excellent for conventional denture retention and stability. The posterior ridge form is an inverted U-shaped and the lateral stability is good to excellent for the prosthesis. The problems associated with the existing denture only and only relates to the amount of retention. The financial commitment of the patient is low, and under these conditions, two implants are inserted in the A and E position. The implants remain independent of each other, not connected with a superstructure. The most common type of attachments used is an O-ring or a ball and a trailer hitch design. Prosthesis movement should be as much as practical, that's PM6. Prosthesis splints these two implants together for additional support while it's in place. The primary advantage is the cost. The existing restoration may often be adapted with a rebasing procedure around an implant, so even the denture might not have to be made again. The disadvantages relates to its relative poor implant support compared to the other options. Okay, these implants are placed anterior to the mental foramina. They are usually in the first premolar region. This results in a curved arch form anterior to the implant sites. The superstructure flexibility is related to its length. 5 times more flexures had the implant be in the B and D position instead of the A and E. The increase in superstructure movements may result in loosening of the coping screws. So we have to understand, okay, that is overdenture system 1. Another problem being is, if we join the A and E implants, the bar is straight and not bent. Therefore, it occupies a more lingual position. If we join a bar here, it occupies a more lingual position, and it also increases the flexibility of the superstructure. So we have to understand that there is a greater moment of force which is created. If the prosthesis rests against the sides of the curved bar, the prosthesis movement is reduced and even be rigid. Therefore, there is much greater load on the implant system. Coming to the overdenture system 2, this is selected only on occasions where the patient's anatomic conditions for a traditional denture again are good to excellent. The posterior ridge form is an inverted U shape. Lateral stability is good to excellent. Patient's complaints are minimal. Again, specifically retention. Patient requires a new prosthesis and is investing little more time and money. The implants are positioned in the B and D position, splinted together with a superstructure without any distal cantilever. The prosthesis should have a PM3 or a greater range of motion. If the bar is often connected on the facial aspect with the implant copings. In this way, the lingual flange of the prosthesis remains within the contour of traditional dentures. Overdenture, option 3. If we see option 1, what is important to understand is that the superstructure connects the implants but is not cantilevered to the distal. This is the usual treatment option for the patients with minor complications. That is, it's not just the retention, even the stability starts to get compromised. If the posterior ridge form is good, the implants are placed in the A, C, E areas. That is overdenture 3 option 1. If that doesn't happen, that is, the posterior position is poor, the implants are placed in the B, C and D region. The posterior ridge form determines the posterior lingual flange extension of the dentures, which limit the lateral movement of the restoration. Poor lateral stability places additional forces on the anterior implants. Therefore, if the patient with poor posterior ridge form requires more stability, more than 3 implants are indicated. The prosthesis movement may be slightly more supportive in the ACE option, which is the overdenture 3 part 1, and the PM2 to the 6 range of motions is reasonable. There are many advantages of splinting the A, C and E implants. What are the advantages? It's that there is a 6-fold reduction in the superstructure flexure. Also limits the consequences of screw loosening, because 3 coping screws retain the superstructure rather than 2. Implant reaction forces are reduced with a 3rd implant as compared to 2 implants. The greater surface area of implants to bone allows better distribution of forces. 3 permucosal sites distribute stresses more efficiently and minimize the crestal bone loss. Because the crestal bone loss is the first affected sign, this is a major advantage. Also, there is twice the reduction in maximum moment of forces with 3 implants and the 2 implants being in the A and C position. The implants again which are splinted in the ACE position should not form a straight line. The C implant is anterior to the more distal A and E position. Okay, this is really important. The restoration benefits from vertical implant support in the anterior arch, and the rotation of the prosthesis is limited if we compare that to the overdenture treatment options 1 and 2. The greater the anterior posterior distance of the A, C and E implants, greater is the lateral stability. The prosthesis must not attach or contact angles formed by the superstructure, otherwise it's got to be too rigid. If a clip attachment is designed for the prosthesis, the bar may connect the facial of the A and E implant copings and to the lingual of the C copings. Okay, moving on to overdenture treatment option 4. In the 4th mandibular treatment option, the 4 implants are placed in the A, B, C and E position. These implants provide enough support so that the superstructure may be cantilevered from the distal implant approximately 10 mm on each side. The cantilever superstructure first makes its presence with 4 implants for 2 reasons. The first relates to the increase in the implant support compared to the previous treatment options. Second is related to additional retention system for the superstructure, which again limits the risk of screw loosening. The patient's indication for this treatment includes poor posterior anatomy, which causes lack of retention and stability, soft tissue abrasions, difficulty in talking. The edentulous posterior mandible is often more resorbed than the anterior region. The buccal shelf, which is my stress bearing area and my retentive area, if it's covered with the buccinator muscles and the mylohyoid, corresponds to the crest of the residual ridge. The patient's complaints and desires are more demanding than the previous treatment options. The prosthesis may have more stability PM2 range of motion is the most common. The attachments are often placed in the distal cantilevers and in the midline. Prosthesis is RP5 but has the least soft tissue support than the other soft tissue supporting overdentures. The anterior attachment must be able to disengage from the bar to permit rotation of the distal attachments. The patient obviously benefits from the 4 implants because there is greater vertical support and lateral stability. The prosthesis only loads the soft tissue over the second molar and the retromolar pad area. The amount of distal cantilever is related to the force factors and to the anterior-posterior distance from the center of the most anterior implant to the distal portions of the A and E implants. If the arch form is square and the anterior-posterior distance is reduced, the implants may be placed in the A, B, C and E positions for patients chewing primarily on the right side. Okay. Coming to the overdenture treatment option 5. A mandible implant overdenture 5 is designed for patients with moderate to severe problems related to a traditional restoration. The need and desires of the patient are most demanding. It may also include limiting the bulk or the amount of prosthesis, major concerns regarding function, stability, sore spots, inability to practically wear a conventional mandibular denture. Implants are inserted in each of the positions A, B, C, D, E. The superstructure is cantilevered distally approximately 15 mm, which places it under the first molar area. Restoration usually does not extend beyond the first molar with either teeth or the soft tissue covering. Restoration is RP4, completely implant supported. Superstructure may be cantilevered an average of 15 mm for 3 reasons. Additional C implant increases the implant bone surface area of the system, and the additional implant adds another retentive element. Also, the C position implant increases the anterior-posterior dimension of implant distance, which increases the support mechanism and also helps us counter the class 1 lever action of the distal cantilever. 5 implants also allow the superstructure and prosthesis to be cantilevered forward from the anterior ridge, particularly beneficial for Angle's skeletal class 2 patients. The lower lip is supported by the maxillary teeth when the jaw is at rest. Traditional mandibular dentures reconstruct the horizontal overjet so that lower anterior teeth position does not infringe on the neutral zone during rest or function. What is the neutral zone? It's the buffer zone between the movable components of the cheek on one side and the tongue on one side. Important to know this. Okay, it also increases the amount of function in the anterior region. The distal cantilever is reduced to decrease the lever force. Okay, do we have any limitations? Accurate determination of the space defined by the psychological contouring of the complete denture before and after implant surgery is required during the treatment planning phase for an implant overdenture. This determination assists in formulating the proper surgical treatment plan and in selecting the appropriate independent implant overdenture systems. There is also frequent need for the attachment adjustments and replacement. Prosthesis fracture is one of the common things which are noted. When placing a bar, be it a Hader bar or a Dolder bar, added space is required underneath the dentures. There are also difficulties encountered for maintaining the hygiene. Passivity of the bar, which has to be checked and verified even before placement, which if ignored tend to cause mechanical problems. Also, there are increased additional costs due to the subsequent repair, replacement, fracture charges. So all these things have to be told to the patient at the outset. What helps us in the decision making? Whether we have to give removable or fixed, we have to understand that. Before we go on to that, let us understand what happens as far as the residual ridge resorption goes. The American College of Prosthodontists had come up with a classification wherein we see that if it's a type 1, the residual bone height is 21 mm or greater. If it's type 2, the residual bone height is 16 to 20 mm. If it's type 3, the residual alveolar bone height is around 11 to 15 mm. If it's type 4, the residual vertical bone height is 10 mm or less. So it's important to know the residual ridge height. Only when we know the height will we know the inter-ridge distance. This is what is type 1, 20 mm or greater. Type 2, 16 to 20 mm. Type 3, 11 to 15 mm. And type 4, 10 mm or less. Why is it important to know the residual ridge resorption? Because there is apparent loss of sulcus width and depth. There is displacement of muscle attachments closer to the ridge, loss of vertical dimension both at rest and at occlusion, reduction of the lower face height, an anterior rotation of the mandible, increase in the relative prognathism, morphological changes of the alveolar bone such as sharp, spiny, uneven residual ridges, location of the mental foramina closer to the ridge crest. So what we have to understand is, if there is an 16 to 20 mm of interalveolar space, that is what we keep as a guideline. If we have an increased inter-arch distance, we not only have to replace the teeth, but even the soft tissues have to be replaced. So we generally go in for options which are removable, okay, which would either be my RP4 and RP5 overdenture options. If I have minimal to moderate amount of inter-ridge spacing present, I can go for fixed prosthesis, but it should also incorporate my soft tissues into it. If I have very little amount of inter-ridge space present, I have to go for a fixed prosthesis, or I can also go in for some amount of osteoplasty, creating again an amount of medium to intermediate type of inter-ridge space or distance, and then choosing between fixed and removable options based on the treatment time, based on the treatment costs, patient's affordability. Thank you all. Thank you Dental XP. This is the end of part 1. When we come back with part 2 and the series thereafter, we will be talking about the individual attachments and the treatment modalities with the pros and cons, which situation to use what, and the after effects of such cases. So we need to be prepared for that. Thank you all once again. Cheers.